Okay, I'll read the question again for the recording's sakes. A 40-year-old woman visits the clinic complaining of fatigue. She had recently been treated for an infection. Her laboratory values are as follows: RBC count 1.8, hemoglobin 5.2, hematocrit 15, WBC count 7.6, platelet count 320,000, and MCV is 92, and reticulocyte count is 24%. I want you guys to really focus on the reticulocyte count and the hemoglobin, okay? What is the most likely explanation for this presentation? Aplastic anemia, hemolytic anemia, hereditary spherocytosis, and B12 deficiency.
You can speak, fellas. Just unmute. You don't need to raise your hand.
Um, the reticulocyte count is pretty high, so I'd say it's hemolytic.
Yes. Whoever said hemolytic anemia, you guys are correct, mashallah. The reticulocyte is not normal to be seen in the blood, and this percentage is really high. What else? Yeah, and the rest is the MCV, the hematocrit, the hematocrit, yeah, and MCV, they're all normal. So it's not aplastic or B12 deficiency.
The normal count is like 2% or less, correct?
I think so. I have to check, honestly, the normal ranges, but don't worry about memorizing the normal ranges. You guys usually, the doctor usually provides you with the normal ranges in the exam. So don't worry about them.
Okay. Shall we move on?
Yeah.
So the answer was hemolytic anemia. Okay, this question is mine. So the term glycocalyx refers to which of the following? The negatively charged carbohydrate chains that protrude into the cytosol from glycolipids and integral glycoproteins, or the negatively charged carbohydrate layer on the outer cell surface, the layer of anions aligned on the cytosolic surface of the plasma membrane, the large glycogen stores found in fast muscles, a mechanism of cell-to-cell attachment. So guys, you can just unmute, no need to raise your hand, anything, just unmute and answer.
A lot of people said B in the chat.
B. So
Most of
it
them
is,
said B.
yeah, it is the charged carbohydrate layer on the outer surface of the cell. That is the correct answer, yes. So that's very good, alhamdulillah. If there are any questions, please let me know. I can't find the chat. I might join from my phone so I can look at the chat. Okay, so next question.
Okay, so the next question says, a 60-year-old man complains of headaches, visual difficulties, and chest pains. Physical examination reveals a red complexion and a large spleen. His complete blood count and CBC is as follows: hematocrit 58, WBC is 13,300, platelets 600,000. His arterial oxygen saturation is 97 on room air. Which treatment would you recommend?
Iron supplement?
Why would you say iron supplement?
Because iron deficiency causes anisocytosis, which could mean like larger red blood cells. Or am I tripping?
Okay, so the question doesn't really say if the person has an anisocytosis. Do you know what anisocytosis is?
It's like when the red blood cells have different sizes.
Yes, different sizes. So the question doesn't really tell you if the person actually has different sizes. What the question tells you is that the person has polycythemia or polycythemia vera, which is increased everything, literally. Increased RBCs, WBCs, and platelets. Again, in the exam, they'll give you the normal ranges, but this is very high. Everything is very high. The platelets, 600,000, that's very high. Okay, so also he has increased hematocrit, which increases the viscosity of the blood, okay, resulting in like increased afterload for the heart, which is probably the reason for his chest pain. So phlebotomy is the actual answer. Phlebotomy is, well, basically bleeding out the patient. You literally put a needle in their arm, in a vein or an artery, and you pull the blood out of them because they have way too much of it. You don't really see people with too much blood. You usually see anemias, but this actually can happen. So yeah, phlebotomy is the answer.
Okay, so next question. Yeah, phlebotomy. Okay. No. Okay, so which statement is incorrect of the following? So the term homeostasis describes the maintenance of nearly constant conditions in the body. Is this correct or incorrect? Can someone unmute? It's okay if it's the same person. Yeah.
Correct.
Okay, it is correct. In most diseases, homeostatic mechanisms are no longer operating in the body. Does this happen? The body's compensatory mechanisms often lead to deviations from normal range in some of the body's functions. This does happen. Disease is generally considered to be a state of disrupted homeostasis. That is the definition of a disease, right? So what is the answer? Let me check
C.
the chat. Okay, you said C, right? Okay, so can you tell me why you say C? Or why you might think it's C?
I think it's the term homeostasis, like choice A, it is the actual definition of homeostasis. Choices B and C, it's correct because like diseases, like it's homeostatic mechanisms are no longer operating, and disease is basically considered to be a state of disrupted homeostasis. So B, D are also correct. So this leaves C.
Okay, I see your point of view. I understand how you thought about that. But not most diseases, the homeostatic mechanisms are no longer operating in the body. And this is coming to it in a general way. It's talking about it in a general way. As for C, the body's compensatory mechanisms often lead to deviations from the normal range in some body's functions. This is not wrong. So, for example, if someone has blood loss, okay, for example, someone has GI bleeding, they'll become hypovolemic, right? So their heart will become tachy. It'll beat faster because it thinks that it is hypotensive, right? So that is a deviation from the normal compensatory from the normal range of the body, right? It'll become a higher rate of pumping. As for B, the homeostatic mechanisms are no longer available. They just aren't compensating enough, or the body is confused and can't fix disease using its normal homeostatic mechanisms. So B is the incorrect answer, because the term homeostasis describes the maintenance of nearly constant conditions. And in disease, you try to become nearly constant because it can fail the compensatory mechanism, but not make it worse. Yeah. Okay. So is that clear? I hope it is. Yes. Okay. Good.
Okay, so the next question goes, a 38-year-old healthy woman comes to you for a routine visit. She has spent the past 2 months hiking through the Himalayas. Okay, keep in mind the height of which she spent the last 2 months. Okay, and climbed to the base camp of Mount Everest. Which result would you expect to see on her CBC?
C.
Okay, excellent. Does anyone have any other answer? Okay, so you guys are right. It's C. This is called secondary polycythemia because she has been exposed to really low oxygen levels for 2 months. So her body tried to adjust to that low levels of oxygen. So what her body tried to do is produce more RBCs. Okay, you can't change the level of oxygen you're getting, but you can change the amount of cells that are carrying the oxygen in an attempt to compensate. So her RBC count is high, therefore explains why the hematocrit is high. WBC count should not change, nor the MCV, because it's just a quantitative change in the RBCs, not the qualitative. Is that all clear?
What is MCV? Mean cellular volume.
Okay.
Mean corpuscular volume, to be more exact.
Yeah, mean corpuscular volume. Okay. It's basically the volume of the RBC. How much volume does the RBC has? Yeah.
Yeah, the volume, not the size.
Yeah.
So MCV is well, yeah, okay, kind of you can say the size. Yani, is it micro or macrocytic? Well, MCH, you would say it's hypochromic or nomochromic.
Or high, yeah.
Tamam? So we move on. Okay, so this is a series of 3 questions, so please concentrate with me. Inshallah, it will be very easy. So I would like you to match the cellular location for each of the steps involved in the synthesis and packaging of a secreted protein listed in the list that I'll show you right now. This is kind of good for you guys because you have your mole midterm soon as well. Okay. So these are the options. You have the nucleolus, nucleus, granular, endoplasmic reticulum, agranular. So this is the smooth. Agranular means smooth. You have the granular, which is the rough endoplasmic, Golgi, endosomes, peroxisomes, lysosomes, cytosol or cytoplasm, cytoskeleton, glycocalyx, and microtubules. Okay, so a protein, for protein condensation and packaging, where does this happen?
Golgi bodies?
The Golgi apparatus. Yes, you are correct. That is correct. That is correct answer. Golgi. Yes. E is the correct answer. So secreted proteins are condensed, sorted, packaged into secretory vesicles in the terminal portions of the Golgi apparatus. Okay. So initiation of translation. Where does this happen? I found this in your slides, like just a sentence. Cytosol, cytoplasm. Any more answers? How many questions? Many.
Never mind.
No, say. Come on. Make mistakes.
I was gonna say granular, endoplasmic reticulum, but then I don't know, I just remember seeing a figure.
Okay, so your idea isn't wrong, but it is the cytosol initiation of what was the question? Translation? Yeah, translation. The granular endoplasmic reticulum, or the rough, has ribosomes, and ribosomes have proteins, and proteins make up, or they are there well for transcription rather than translation, right? Okay.
Well, I think I realized why I got it wrong. It's fine. Sorry.
Okay, good. Okay, so yeah, it was cytosol. Okay, so where does gene transcription happen? Gene transcription. Some people said nucleolus. Okay, someone said nucleus. Nucleus, yes. The nucleus is the correct answer. So all the transcription events occur in the nucleus, all of them, regardless final destination of the protein, whether it's going to go to the to be stored in the vacuole, whatever, or it's going to be sent outside. They all get transcribed in the nucleus. This is Baan's question.
Okay, so the question goes, a 34-year-old man with schizophrenia has had chronic fatigue for 6 months. He has a good appetite, but he has refused to eat vegetables for 1 year because he hears voices saying that vegetables are poisoned. His physical and neurological examinations are normal. His hemoglobin level is 9.1. His leukocyte count is 10,000. His MCV is 122. What is the most likely diagnosis?
Everyone already answered. Sisi, when you started reading the
Amazing.
question.
Wallah, amazing. You guys are mashallah pros. Yeah, it's E. Can anybody explain why it's not why it cannot be B12 deficiency?
Very good question.
Because B12 comes from animals.
Can I say?
Oh,
Yeah,
my
of
bad.
course.
Because B12 stored in the body for 2 to 4 years, so it takes 2 to 4 years to have B12 deficiency.
Exactly. B12 can come from vegetables, but your body stores vitamin B12 for at least or like max 4 years, 4 to 5 years.
Yes.
So he has been on a strike for 1 year. So it can be vitamin B12. So it's folic deficiency, folic acid deficiency.
May I add to that, Ban?
Of course.
Does anyone know how long folic acid is stored? It's not very important, but I just thought I would ask.
A few days.
No, 3 to 6 months. So that's it's something you can keep in mind, but it's not very important in my opinion. What is folic acid? Folate, maybe? You know folate? It's folic acid. It's the same. Anything that says 8 at the end, you can just remove the 8 and say acid. It's the same
Acid,
thing.
yeah.
So like glutamate is glutamic acid. Aspartate is aspartic acid.
Folic acid is important in DNA synthesis.
Someone said a few months. Yes, that is correct. Yeah, a few months. I'm sorry I didn't see it before I answered. So folic acid and B12 deficiency, they cause megaloblastic anemia, right? Does that answer your question, Mubarak? I hope it does. Okay, shall we move on?
There's a lecture, B12 and folate
Folate
deficiency. Yeah.
All right, moving on. Okay, so which of the following best describes an attribute of visceral smooth muscles not shared by skeletal muscles? This one might be quite tricky.
Is it B?
MashaAllah, yes, it is B. So smooth muscle contracts in response to stretch. Does anyone know why? Would you like to know why?
Oh, I know.
Go ahead.
Because don't the cells, I don't know the specific like molecule, but a channel opens, right?
Okay.
Like calcium?
So when they stretch, some channels open. Is that what you're trying to say?
Yes.
Okay, so the stretch results in the depolarization and potentially the degeneration of action potentials. But yes, it's because of the channels that open up when they're stretched. So calcium, like you were saying, yeah, it is calcium. Calcium, yeah, it is calcium, I believe. Inshallah, I'm not making a mistake. If someone has any correction to anything I'm saying, please let me know. So yes, be like our friend said. Okay, moving on.
Okay, so the question says a patient presents to your office complaining of extreme fatigue and shortness of breath on exertion that has gradually worsened during the past 2 years, or 2 weeks, sorry. Physical examination reveals a well-nourished woman who appears comfortable but somewhat short of breath. Her vital signs include a pulse of 120, a respiratory rate of 20, and blood pressure of 120/70. All of these are normal except for the heart rate is a bit raised. When she stands up, her pulse increases to 150 and her blood pressure falls to 80 to 50. Her hematologic values are as follows: hemoglobin 7, hematocrit 20%, RBC count 2, and platelet count 400,000. On a peripheral smear, her RBCs are microcytic hypochromic. What is your diagnosis?
Iron deficiency.
Exactly. Oh my God. You guys are amazing. MashaAllah, tabarakallah. Yeah, it's iron deficiency anemia. A very classic presentation of iron deficiency. microcytic and hypochromic. Microcytic means too small, and hypochromic means decreased intracellular hemoglobin concentrations. So yeah, I don't think I need to explain further. You guys are amazing, inshallah.
You see hypochromia, microcytosis, iron deficiency. Move on.
Yeah.
As well as B12 folate, megaloblastic, move on. Or vice versa, megaloblastic, B12 folate. Okay, good. Everyone good, inshallah. See. Come on. So the resting potential of a myelinated nerve fiber is primarily dependent on the concentration gradient of which ion? The resting potential. So yes, mashallah, Hafsa. Very good. Yeah. Alhamdulillah, you guys know this well. It is potassium. It's great, mashallah, mashallah.
Okay. So the next question, if you have studied this lecture, you would answer immediately by looking at the picture. The question says a 9-month-old boy presents with failure to thrive and pallor. His CBC shows low CBC and low hemoglobin A or hemoglobin. A peripheral blood film is attached. Which of the following is the diagnosis for this patient? Yeah, mashallah. Yeah, let's see. This picture is very classic for thalassemia major. Yeah, that's the answer.
This picture is gonna come in your exam. This exact same one. See
Yeah.
this V?
Yeah.
You see this V? Would you see it? Put thalassemia major.
Stick to Dr. Rayhan's whatever he puts in his slides, that's what's coming in the exam, inshallah.
The A and F count? You mean the alpha and the gamma subunits?
Yeah, the hemoglobin A should be very low and the hemoglobin F should be
Oh.
very, very high in thalassemia major. But in this question, you don't really need it because the picture gives it away. But you can also make the diagnosis from the patient being a 9-month-old. Okay. Remember, thalassemia happens when the baby is trying to switch from hemoglobin F to hemoglobin A. That's when the disease manifests itself. So that's when the disease appears in babies. So you can kind of link that disease to the age of the patient.
Isn't it fetal to
Yes,
beta?
fetal
Yes.
to beta. Yeah, it's from hemoglobin F to hemoglobin A. Hemoglobin A has 2 alpha chains and 2 beta chains. Yeah, you're right.
Fetal is gamma, alpha and gamma, 2 alpha, 2 gamma, and hemoglobin A, like Baan just said, is 2 alpha, 2 beta. Tamam? So the answer is C. Okay, some muscle physiology. Calmodulin is most closely related, both structurally and functionally, yeah, to which of the following proteins? Yeah, troponin C, right? This is one's easy to memorize, right? C, calmodulin, troponin, calcium, calmodulin. Then we have calcium calmodulin complex. There are a lot of things that they both need calcium. Yes, there you go. Yeah. Yes. Yes. Good. Good. MashaAllah alaykum. Okay, خلاص تمام.
Okay, so this question is kind of a recall question. It says, which of the following is referred as a qualitative hemoglobinopathy?
Sickle cell?
Yes. Yes, mashallah, you guys are amazing. Sickle cell. Remember in the lecture, we said that there are 2 types of hemoglobinopathies, qualitative and quantitative. And the qualitative, we took only one example, which is sickle cell. The quantitative, we took thalassemia.
Moving on. Okay, next question. Which of the following decreases in length during the contraction of a skeletal muscle fiber?
Z-disc?
Try again.
Oh, my bad. My bad. Okay, I got it.
Okay, make mistakes here so you don't make them in
It's
the exam.
okay. This is the time to
True.
make mistakes.
Yeah.
True.
I always feel so good when I make a mistake when I'm solving questions, because then I realize what I misunderstood. And you don't realize what you misunderstood until you solve questions. This is something I tell anyone who asks for advice: solve questions after every lecture.
It
Exam
feels
committees
bad. It
for a
feels
reason.
bad in the beginning. You feel like I just studied the
Yeah.
lecture. Why am I not
Why?
getting the question right? But يعني, you're gonna do yourself a favor.
This recording will be posted on the GND YouTube channel. Inshallah, we'll ask your BLCs, or we'll ask our coordinators to contact your BLCs with the links.
Yeah, inshallah, they'll send you the link, inshallah.
So be the I-band of the sarcomere. And here's the explanation if anyone wants to read. Yeah, the I-band.
We'll also send you the PowerPoint, inshallah, after we're done.
Yes, inshallah.
So this question says a 35-year-old apparently healthy man undergoes a medical examination while applying for life insurance. He is not anemic, but his hemoglobin electrophoresis is reported as the follows. Hemoglobin A is 62%. Hemoglobin S is 35%. You guys are already answering. Hemoglobin F is 1%. Hemoglobin A2 is 1%. Inshallah, yeah, a sickle trait. You guys really have to remember the percentages. Dr. Rayhan provided a chart for the percentages in the end of his lecture. So how to differentiate between sickle trait and sickle disease and hemoglobin electrophoresis. In trait, it should be less than 50. Yes, Ayel, you're right. Should be less than 50. And disease is above 50%.
Yes, so trait means he's a carrier for we didn't follow. Very good question. This is very important. That whole table, no hemoglobin A in sickle cells?
There is hemoglobin A in sickle cell. There is, as you can see, hemoglobin A, 62. Hemoglobin A1 is the same as hemoglobin A. Hemoglobin A2 is the one that we target to diagnose thalassemia. In thalassemia major, we have, not major, minor, we have A2 above 3.5%.
So the problem in sickle cell, like what was explained in Baan's lecture, is just morphological, right? They become sickle shaped, kind of like what is it called, the one in Minecraft, the hoe, the one for getting up the grass or stuff. Kind of looks like a sickle.
Yeah.
Like the Soviet Union thing. Let's see. All right. Can we have sickle trait and thalassemia? Yeah, sickle thalassemia. You can have.
Yeah. It's mentioned really briefly in the lecture.
Yeah, in the electrophoresis. In the electrophoresis, there's the little thing with the blood things. You can have both. This is very important. It's very, very likely gonna come in your OSPE. Okay.
Yeah, it's really high yield. That lecture is really high yield.
Yeah, so please make sure you study it well, tamam. Okay. Tetanic contractions of a skeletal muscle fiber results from a cumulative increase in the intracellular concentration of which of the following? Yes. So, mashallah, the cross-bridge cycle is very good. You guys, mashallah, studied is very good. Yes, calcium. B. Yeah. Oh, okay, good. Does anyone need the explanation? I don't think, right? Okay. Mashallah, good. Alhamdulillah. طيب, تمام.
Okay, so this question says, which one of the following is correct interpretation of the hemoglobin analysis results in the attached picture? There is no attached picture. Yeesh. Okay. Yousef, I'll send you the picture and just add it to the slide, okay?
Okay, maybe I can just. I'm not sure. Can you guys see anything on my screen other than the PowerPoint?
No, it's just the PowerPoint.
Okay.
Wait, can you guys send it through like the chat itself? I think you can.
So you guys can't see anything else on my screen, right?
No.
Okay, send me the picture on WhatsApp and I'll just.
Yeah. I just sent this.
I muted you by accident.
Yeah, you can.
It's fine. It's fine. I sent the picture.
Okay, copied.
Sorry about this, guys. Pretty sure I added it last night.
Okay, here I sent it to the person organizing this meeting. Okay. Read it. She'll put it in the chat for you guys.
Oh, the
he
question
will,
is
I'm sure.
the question is repeated, Yousef. Go to slide 140.
Allah, خلاص, we'll just put the picture here.
I added the question again.
Oh,
Yeah, because I forgot the picture and I added it in different slides.
خلاص, then we'll just skip it when we get to it.
Okay, خلاص, we'll skip this
Here.
question and we'll get to it again.
Here, I sent it, but G&D also sent it. Here's the picture. Look at it.
Let's see, since HbA2 is over 3.5.
Yes, it's
140.
thalassemia major.
Yes, there are 140-ish
Yeah.
slides. There are actually 164.
160.
But it's because the slide is a question and then the other one is the answer, and
Yeah,
there's like
and I added
slide.
slides. Yeah, and I added the slides for explanation, like charts and stuff, so they're not all pictures.
Yeah.
They're not all
And there are
questions.
many 3-part questions because hemoglobin F is increased. Yeah. It's thalassemia major, right?
Yes, it's thalassemia major.
Yes. Which slide are we on? We're on slide 50. What lecture is this from? Isn't this from
hemoglobin
hemoglobinopathies?
hemoglobin electrophoresis and
And
hemoglobinopathies. Yeah.
Okay, tamam. So weightlifting can result in a dramatic increase in skeletal muscle mass, which is called hypertrophy. This increase in muscle mass is primarily attributable to which of the following? Someone said D. Okay, why D? You said, what'd you say?
Oh, I said B. Somebody else said
Okay.
D.
No, B is right. Okay, I want to know the person who said D. Why did they say D? How do we know if it's alpha or beta thalassemia? Well, okay, wait, let me just finish this question and inshallah we'll explain that. Yeah, it is B because hypertrophy, right? And individual muscle fibers. Hypertrophy is the increase of the size of the muscle cells. There's hypertrophy and hyperplasia, right? Smooth muscle can undergo hyperplasia, but cardiac and skeletal cannot. They can only undergo hypertrophy, which is increase in the size, not the number. Hyperplasia is an increase in the number of the cells. Does that answer your question, Noor?
And atrophy is loss of cells.
Yeah, or mass. Yeah, loss of cells. Yeah.
Yeah,
Yes,
or like
okay.
shrinkage. Yeah.
Come on, okay.
I go to the next question.
This
This is
one's
repeated.
repeated.
Yeah.
Okay, so this one is also a 3-parter or a 2-parter actually. So the above figure shows the changes in membrane potential during an action potential and giant squid axon. If you guys did A levels or just studied for foundation, then you heard a giant squid axon a lot. Refer to it when answering questions 13 and 14. So this is action potential. Okay, question 13. Which of the following is primarily responsible for the change in membrane potential between points B and D? Between B and D.
Sodium increase.
Sodium movement into the cell, yes. Yeah. So action potential is very, very, very important, okay? Yes, D. Okay, 14. Which of the following is primarily responsible for the change in membrane potential between points D and E? D and E. So
Movement of potassium out of the cell.
say that again, please.
Movement of potassium out of the cell.
Yes, movement of potassium out of the cell because potassium is positive, right? So if it goes out, will depolarize, right? Sorry, repolarize. Yeah, so C. Potassium out. So sodium in, potassium out, repolarize, hyperpolarize, stimulate, go to negative 55, which is the threshold, sodium in, and cycle continues. Baan.
Okay. So this question says, what condition leads to a deficiency in factor IX that can be corrected by an intravenous injection of vitamin K? Yikes, is this a hard one?
Is it
This is
A?
from the coagulation lecture, right?
I think it's coagulation.
I think this question came in our final, right?
I think
The
so,
only
yeah.
thing I recognize is D, so I'll probably go with that. It makes a lucky guess.
So what does antithrombin do?
It's anticoagulation.
Yeah,
Yes, it's
antithrombin.
antithrombin.
Yeah.
So it's antithrombosis. So whoever answered A, you guys are correct. That we have many types of hemophilia. And hemophilia, I think B, yes, hemophilia B is a genetic loss or genetic mutation of the clotting factor 9. Okay? So many clotting factors are vitamin K dependent. You cannot form them or synthesize them without vitamin K. So that's why we can fix this deficiency by injecting the patient with vitamin K. This is from the coagulation lecture. Can you go,
repeat that
Yousef, go
last
to
part?
the...
I think
Can you say that again?
Can you repeat that last part, please?
Okay, Yousef, go to the next slide.
Yeah, it says C, but the answer is A, okay? It's not, the explanation is not there, okay?
Yeah, so this is the coagulation cascade. We have two pathways. If anyone studied the lecture, you have an intrinsic pathway and an extrinsic pathway. Okay, and hemophilia, we have three types of hemophilia: hemophilia A, hemophilia B, and hemophilia C. Hemophilia A is a deficiency in clotting factor 8. Hemophilia B is clotting factor 9, and hemophilia C is clotting factor 12 or 11, I think 12. So
So it's CBA 12, 11, 9.
yes. No, 12, 9, 8. It's not 11 doesn't have an hemophilia.
Okay, my bad.
Okay, so I added this picture for your guys' convenience, so you can go back to it. So yeah, I'll go back to the lecture just a sec. Okay, so hemophilia A is 8, hemophilia B is 9, and hemophilia C is 11. So they're going backwards. A is 8, B is 9, C is 11.
Okay, my bad. I said 12 instead of
Yeah. And all of
8.
these are vitamin K dependent. That's why
I
we're
moved
fixing
up.
it with an injection of vitamin K.
See, that's the problem with memorizing it as a line rather than the actual thing. I moved it up one factor. Okay.
So I also put this chart for you guys because heparin and warfarin was mentioned by Dr. Abdul Jabbar. I want you guys to know that warfarin inhibits vitamin K dependent clotting factors, which is what I just told you. 2, also we have 7,
5, 9,
9, 10, yeah.
7, 9, 10, sorry. And
Uh,
CS.
and heparin potentiates antithrombin. What does potentiate mean? It means activate. It activates antithrombin, and antithrombin breaks down thrombin or inhibits thrombin, so it inhibits the clot formation in general. So you guys have to memorize what warfarin or which pathway of the clotting cascade warfarin works on. So warfarin works on extrinsic and heparin works on intrinsic, and both work on the common pathway. Okay? I know it's highlighted over here that that warfarin crosses the placenta and heparin does not. I don't think that's really important in your stage right now. Do you think so,
But
Yousef? Do you remember something like this?
keep it in mind because I remember something about pregnancy. So like if they said there's a pregnant lady, you would use heparin, but I don't think they would ask you like
Oh,
a question that's very like pharma based. But
okay.
just keep in mind, yeah, because if you see pregnant, then she's probably on heparin,
Mm.
right?
And you also guys have to remember which tests which clotting cascade and which drug is monitored by that test.
So
Okay, so
PTT and PTI.
yes, PTINR is used to monitor warfarin, and it's for the extrinsic pathway.
Yes.
PTT is for the intrinsic pathway, and it's used to monitor heparin.
So a good way to remember this is intrinsic is so inside. So you play table tennis, PTT, inside. This is courtesy of my PBLTA. Okay, so it says C, but the answer was A. As you see here, hemophilia. Okay. Okay, next question. Very nice slide. I like this picture. Anyway, the delayed onset and prolonged duration of smooth muscle contraction, as well as the greater force generated by smooth muscle compared with skeletal muscle, are all consequences of what? So someone said E, slower uptake of the calcium ions after
D.
after contraction. You said D? Can you say that again?
D.
D. Yeah, D is the correct answer, yes. So slower cycling rate of smooth muscles, muscle myosin cross bridges. So I know the answer is simple and you wouldn't think that would be the answer, but yeah, you would think more of a ionic thing, right? But that's just simply it. The cross bridging is just slower in smooth muscles. Come on. Is anyone confused? Because okay, if anyone has any question, just unmute. Okay.
Okay, so someone asked me what is C and S factors. These are other clotting factors that are not like heavily mentioned, but these also like contribute to the clotting cascade. They're not in the intrinsic or extrinsic pathway, but they contribute from outside.
Though I remember there was a question about them, because I think they were important for the شو اسمه Glanzmann's thrombasthenia and the other one I always forget its name. Those were in biochemistry, I think. Glanzmann's and the other one. No, not biochemistry actually. It was one of the hands lectures. It's good to keep in mind. I'm not sure if they gave it to you guys though. It's probably in one of the hematology lectures. Okay, this is Baan's question.
Okay, so which of the following causes some malnourished patients to bleed excessively when injured?
Is it D?
No, think again.
Is it A?
Yes, it's A. Because this patient is malnourished and vitamin K is obtained from the diet. So that will cause a vitamin K deficiency. And as I said before, many clotting factors are vitamin K dependent. You must have vitamin K to produce these clotting factors. And this is from the coagulation lecture also, as well. It's a really complex lecture, you guys. And it has a lot of information. Like you must go over it more than once.
Yes, coagulation is very high yield, and someone asked which factors do CNS affect? They affect 5 and 8, I believe. So yeah, the answer is A here. Yeah, please study coagulation well, okay? All of heme, it's honestly because the information is very limited. They can't go outside the lectures really. So just please
Yeah.
study them well. Tamam? You are most welcome. Okay, so 3 questions and 1 slide. Let's do this. Okay. Point at which the membrane potential is closest to the sodium equilibrium potential.
D.
Yeah. So do you remember what's the sodium equilibrium potential, or close
I
to it? You
think
don't have to.
what is it? 50 or 30? Between 30 and 50.
It's around 60, 65, yeah. But usually the action potential gets to around 35. Here it says 20. Usually it gets to around 35. But you're not far, yeah. صح. Yeah, it's higher than the action potential basically. It's very like some sources will say 52, some will say 60, some will say 75. So just know it's higher than the actual action potential. تمام. Question 17. Point at which the driving force for sodium is the greatest. Someone said B.
B.
So is there a lower point on the graph than B?
Yeah, there's F.
Yeah, so the lowest point would be the greatest driving force for sodium, right? Because it's farthest from sodium's equilibrium potential, right? So the more negative you go, the more sodium wants to go into the cell and make it more positive. So F is the correct answer. Tamam? So no, it's okay. يعني you should be happy that you made this mistake here. So خلاص you understand that, you understand this concept now. So look at the side of which the equilibrium potential of this ion is. So like, for example, sodium and chloride, their ions, their equilibrium potentials are very positive. So the lowest point on the graph would be the highest driving electrical driving force for these ions. As for potassium, it's very negative. So the highest point on the graph would be the highest electrical driving force for potassium. But then, so a point at which the ratio of potassium permeability to sodium permeability is the greatest. You can just speak, Asma. You don't have to raise your hand. And if that was by mistake, then you can just guess. So someone said D. Someone said F. Yes, F. F, yes, because it's closest to its equilibrium potential, right? Sodium to potassium to sodium. Yeah, it is. It's F. No, not D. It's F. Okay. Is there anything that anyone would like me to explain here? Can we like remove this drawing?
Oh, can you please explain the 18th one?
18th. Okay, so the point at which the ratio of potassium permeability to sodium permeability is the greatest. So which point on the graph is potassium more permeable than sodium, right? So can sodium enter the cell at point F? This is the refractory period, right?
No, but it also can't enter at point E.
No, it can't, right?
So why is it not E? Why is it F?
Because it's most permeable to sodium at point F. Sorry, potassium.
So the question means يعني potassium permeability to sodium, it means like when is potassium more permeable than sodium?
Which point is the greatest difference between the permeability of potassium compared to the permeability of sodium? So basically, it's a 2-point question. Which point is the least permeable to sodium, and which point is the most permeable to potassium at the same time?
So the lower you go, the higher permeability to potassium and the lower permeability to sodium.
And yeah. So it's because it's relatively close to the equilibrium potential for potassium. Does that answer your question?
I have
Layla?
a question.
Yes, go ahead.
What if they switch it? Like they want the ratio of Na to potassium. Is it the same?
Yeah, so no, I would say I would say it would be about around point B, right? Because around point B is when we got to the threshold, right?
Yes.
Yeah. So when we get to the threshold, we have a massive influx of sodium, which will depolarize our nerve fiber or our muscle cell or whatever, right? And potassium will stay in the cell, will not move out. So it's not
Yes.
very permeable for potassium, right?
Yes, thank you.
What is the answer for 18? It is F. So here, let me just, the answer is in front of you guys. G, F, F. Are there any other questions before we move on? I think this is the last action potential question. Okay, 17. Point at which the driving force for sodium is the greatest. Okay, so we have a chemical driving force and we have an electrical driving force, right? So the equilibrium potential for sodium is around positive 60 something. So sodium wants to make the cell positive intracellularly, obviously. So if the cell is more negative, sodium would be more agitated. I want to go into the cell and make it more positive. The answer was D. So the more negative you go, the more sodium would want to enter the cell and make it more positive and closer to its equilibrium potential. The answer for 16 was D. Does that answer your question, Hiba? Yes, okay. You're welcome. Any other questions before we move on? Because this is very, very important. Honestly, this whole block is very important. Like, I'm sorry for you guys. Okay, so no questions. Are the questions gonna be like this? You might get something similar to this in an SAQ, yes. Okay, wait. But at F, the potassium channels are closing slowly, while at E, the potassium channels are open fully. So isn't it more permeable at E? Okay, it's more permeable for potassium, but it's not as less permeable for sodium. So the question was asking about the ratio, right? I have a doubt. If the driving force for sodium is greatest at F, then how come potassium permeability is more than sodium permeability? Okay, the driving force is great, but the permeability is not. It's not open for sodium yet. The cell at this point is hyperpolarized. It's way below threshold. The threshold is here at around, well, here it says around 65-ish or 70. Usually the threshold is around negative 55. At the threshold, the sodium channels open. Before that, the sodium channels do not open. So during this, the sodium channels are inactivated and then they close here. So during this, which is the absolute refractory period, they cannot reopen, right? And here they're closed, they're fully closed, shut down. Now we can reopen them if a stimulus is high enough to reach the threshold. So you have to differentiate between the driving force and the permeability. The driving force is if I make the cell membrane permeable, how quickly and how much of this ion will move through. The permeability is how much can move through right now at this point. Driving force is the permeability. Yeah, okay, I just answered this question. So please differentiate between permeability and driving force. Driving force is how much the ion wants to move, and permeability is how much the ion can move, whether the channels are open or not, whether we are at its opposing electrical potential so that it does move. If there are any more doubts, please ask now. So does everyone understand the difference between permeability and driving force? Yes. If someone doesn't understand, please, I'll explain it again. This is too important. You can't make action potential question mistakes. They're guaranteed questions. Haram.
Can you explain again?
So the difference between permeability and driving force?
Yes.
Okay. So there are factors that allow ions to move through the cell membrane. 1, the concentration gradient. 2, the electrical potential. And 3, permeability. So if the electrical potential is high, so let's say we are at point B, so it is very negative, and sodium's equilibrium potential is about positive 60, then sodium has very, very good reasons to move into the cell. The cell is negative, and sodium wants to bring it closer to it to become positive. That's electrical driving force. Concentration driving force or chemical driving force is when there's higher outside compared to inside. Simple diffusion, osmosis, all of that, you guys know this. Permeability is when we get to point B or the threshold, the sodium channels open, the voltage gated sodium channels. They will open, and when they open, they become permeable. Permeable means the ability to go through, permeability. Some membranes are semi-permeable, some membranes are permeable, depending on the channel, the stuff like that. Does that explain it better? Okay, good. So I'll move on. You're welcome. Okay, Baan.
Okay, thank you, Yousef. So this question says, which of the following would best explain a prolonged bleeding time test?
See?
Yes, amazing. It's C. So there are 3 tests that we do to test the platelet function. We have PT-INR, PTT, and bleeding time. Bleeding time is a general test. Okay, so it tests the function of literally everything. So the only general explanation that would explain a prolonged bleeding time is thrombocytopenia, which is a shortage of clotting factors and clotting cells and platelets in general. So yes, I think this was from platelets and endothelium or coagulation or both. Both of them, most likely coagulation.
Yeah, the heme is very difficult to kind of figure out which lecture this stuff was from.
Everything is interlinked. Everything sounds the same.
Yeah, true. Tamam, so we said it was C, right?
Okay, do you guys want to have a
Someone
break
said
now?
it's, sorry. Someone said this from the coagulation lecture.
Yeah, okay, good.
Okay.
Do you guys want to have a break now, like 5 minutes or 10 minutes, whichever you like?
We can keep going if you want, but if you want a break, we can have a break.
Okay.
Okay, so how many, you gave me the controls back. Thank
Huh?
you. You gave me the controls back when you spoke. Okay, so let's presenter. Okay. Shall we begin?
Yeah.
Wait, I'll join the Zoom on my phone. It keeps leaving.
You're on question 19, your questions.
My question, tamam, okay.
Yeah.
I was just joining so I can see the chat. No audio, chat, okay. Okay, Bismillah. So we finished this one, right?
Yeah.
Okay, simple question, inshallah. What are red blood cells also known
A.
as? Okay, yeah. They're known
Don't
as
even finish the
erythrocytes.
question. They're like, hey, خلاص.
I thought this was important to say because a lot of people, including me in first year, I didn't know that an erythrocyte was a red blood cell. Yeah, erythrocyte. Okay. So yeah, very simple explanation.
Okay, so what is the primary mechanism by which heparin prevents blood coagulation? I showed you the charts before, if anyone remembers it.
A.
Yes, it's A, antithrombin activation. which inhibits thrombosis, yeah. So it's an antithrombotic, basically.
Come on. Okay, in a normal healthy person, which of the following blood components has the shortest lifespan? This one's tricky.
Could it be macrophages? Or no? No, it's
It is not macrophages.
RBCs.
Yeah, so erythrocytes. So the reason this is confusing is because macrophages can have a shorter lifespan than erythrocytes, but they can also have a longer lifespan. So erythrocytes, yeah.
So, another question. So, anything that has to do with memory, like lymph cells, they have one of the longest, right?
Yeah, usually lymphoid cells have, or white blood cells have a long memory. Yes, I have my controls back for G&D. No problem. Okay, so I guess I answered this question. Okay.
Okay, so which of the following is finally responsible for the lysis of insoluble fibrin clots that form within blood vessels? Okay, a lot of mixed answers. It's A, plasmin. Plasmin is a protein that breaks down fibrin clots, and it comes from another protein that's called plasminogen. Okay, it's called a zymogen, which means it's an inactive enzyme. Okay, it gets activated by tissue plasminogen activator. This is a tricky question, but the question is asking for the substance itself. Tissue plasminogen activator is the enzyme that turns plasminogen into plasmin. You can't answer plasminogen because it's inactive. You can't answer B because they didn't ask for the enzyme, and D and E have nothing to do with breaking the fibrin clot. Okay, so is it clear?
Yeah. So that whole thing, the prothrombin, thrombin, fibrinogen.
Yeah, the
plasminogen,
picture I
plasmin,
added in the picture explains fibrin clot lysis.
Okay. Which of the following best describes the correct temporal order of events for skeletal muscles? This should be, inshallah, simple. Someone says E. E. Someone says E. Yeah. Yeah. So the nerve, then the muscle, action potential, then the muscle contraction, right? Yes. Yeah. Okay.
Okay.
Good.
So a patient is concerned that her gums have been bleeding when she has brushed her teeth for the past 3 weeks. Okay. She recalls digestive problems. Remember, digestive problems and episodes of steatorrhea over the past couple of weeks. Steatorrhea means fat and stool. Okay. Which she tries to ease by drinking large amounts of herbal tea. Her prothrombin time is 18 seconds and the normal is 10 to 13. Her partial thromboplastin time, PTT, is 36 and the normal is 25-35. Her platelet count is normal. Laboratory analysis would most likely indicate a deficiency in which of the following vitamins? Okay, mashallah. Yes, it's E, vitamin K. Because again, it is absorbed through the GI from the diet, and if she has digestive problems, that means she can't digest or absorb vitamin K from her diet properly. So she's going to be deficient. And yeah, that's basically it.
Good question. Tamam. Which of the following best describes a physiological difference between the contraction of smooth muscles compared with the contraction of cardiac and skeletal? Someone said B, Faisal. He's sitting in the other room. Yes, yeah, B is correct. صح. Does not require an action potential. Alhamdulillah, good. I thought you guys would be confused by this one, but it's good. Shatta.
As you can see, guys, vitamin K has been repeated over and over again. We are basically hinting that this is such a high yield vitamin for this block, okay? So the question says, which of the following causes some malnourished patients to bleed excessively when injured? This is very similar to a lot of questions I have brought, and I repeated a lot of questions for a reason. It's vitamin K deficiency. Okay, guys? Okay, alhamdulillah, everyone looks like they understand.
Yeah. Know
Alhamdulillah.
everything about vitamin K. It's lipid soluble. Yeah, I'll give you that too.
Yeah.
DEAK are lipid soluble. DEAK. Okay. DEAK. What are red blood cells primarily composed of? Primarily. Hemoglobin. I thought some of you would say like alpha and beta globulins and stuff. Okay. Yeah. Hemoglobin.
Okay. To what protein does von Willebrand factor normally bind to on the surface of platelets? This is a recall question.
A.
Think again.
PF3?
No. Are you guys gonna try everything else and then when nothing works, the right
Guess
answer
again,
is
guess
remaining?
again. Come on.
A lot of people are saying the right answer in the chat, inshallah.
B.
B.
It's B, yes. This is a pure recall. You have to memorize which proteins or receptors on the platelet bind to which on the endothelium, which receptors or proteins are responsible for rolling, which are responsible for adhesion, and how is the, what's it called? The diapedesis or diapedesis
Yes.
to
So moving
the, yeah,
diabetes.
this is all pure memorization.
Coagulation, yes. I believe so. This is from coagulation, right?
Yeah. It's actually from platelet and endothelium also.
I mean, it makes sense.
Yeah.
Okay. So yeah, B. I want to ask if they know the rest of these, but I want to answer the other questions first.
There is another question that's related to this, and I have a whole what's it called? A picture for rolling and adhesion and everything.
The whole like a coagulation process.
Yeah.
Or okay. So what's the major task of red blood cells? Very, very, very simple.
B.
Yeah, D. Okay, moving on.
Okay, so which of the following applies to cytotoxic T cells?
C.
Yes, C. They're activated by the presentation of antigen by an infected cell. You guys have to know the cascade of inflammation. What happens in the body as soon as the microbe enters the body? What is activated first? You have to learn the cascade, and a really great way to learn this and memorize this is to tell it as a story. Act like you're telling your 7-year-old brother this whole thing, this whole cascade. Try to explain it to a child. It'll really stick in your brain like that. So yeah, you guys are right.
One of the best ways to memorize is to explain.
Yeah.
Okay, which statement about cardiac muscle is most accurate? So someone says the strength and contraction of cardiac muscle depends on the amount of calcium surrounding the cardiomyocytes. You are absolutely correct, Saad. Correct, yeah. Does that mean? Okay. So yeah, B. I'll move on. Okay.
Okay.
So I have a question if, I'm sorry, if
Go ahead.
calcium is low in the cardiac muscle, there won't be contraction.
Not won't be. I mean, there will be less contractions, but because you don't have an absolute loss of calcium, right? It's just low. You're hypocalcemic.
Okay.
Does that answer your question?
Yes, thank you.
You're welcome.
Okay, so a 9-year-old girl has nasal discharge and itching of the eyes in spring every year. An allergist performs a skin test using a mixture of grass pollens. Within a few minutes, the girl exhibits a focal redness and swelling at the test site. Remember, a few minutes, okay? This response is most likely due to what is the first thing that would happen? Okay. Congratulations to whoever answered A. A is the correct answer. Antigen antibody complexes being formed in the blood vessels in the skin. This is the first thing that would happen. The rest, they're going to be delayed for a bit. No, it's not the first thing that would happen. Like activation of neutrophils, activation of CD4 helper cells, and cytotoxic T lymphocytes. These all take time. Again, you have to memorize the cascade and what happens first and then second, and everything will help you in solving the questions like this.
Great. Okay. Any questions? Okay. Okay. So, which phase of the ventricular muscle action potential is the potassium permeability highest? Come on, cardiac action potential. Important. Someone said phase 3,
D.
3. Say that again?
It's D.
D, yeah. Yeah, okay, good.
Okay. What will occur following presentation of antigen by a macrophage or macrophage? This is the same question I asked a couple of minutes ago, but just I changed the wording and I flipped. Yes, it's D. It's activation of helper T cells.
And this concept is very, very, very important.
Yousef, somebody asked why not A in your question.
0. The question is potassium isn't permeable in
Why not 1? Sorry, it
1.
says
Oh,
why not
1.
1?
Okay,
Yeah.
so during phase 1, okay, so during phase 0 is the sodium influx, right? The depolarization, and then it will repolarize a little bit because the potassium will leave, but it's not the most permeable, right? Because calcium will kind of rewire that and plateau, right? Yes, vessel plateau. Because of the calcium influx and the potassium efflux. But the most permeable is during phase 3 because that's when most of the potassium will be leaving, right? So it's the highest permeability. Yeah, we get that because of the amount of potassium that's leaving. So we understand that there's more permeability compared to phase 1. Okay. You're welcome. We finished this?
Yeah.
Okay. Which of the following solutions, when infused intravenously, would result in an increase in extracellular fluid volume, a decrease in intracellular fluid volume, and increase in total body water and osmotic after osmotic equilibrium? Keyword after osmotic equilibrium. Okay, I want someone to unmute and explain to me why, because this is one of the topics that you guys really wanted explained.
Can I try?
Yes, go ahead. تفضل.
All right, I'd go C. Why? Because you're adding 1 liter, so that's the increase in volume, in extracellular fluid volume, and
مظبوط.
then NaCl will make the osmolarity in the ECF higher, correct? So
صحيح.
water, sorry?
صحيح. You're right.
Yeah, and water from the ICF to counteract this will move to the ECF, which will decrease the intracellular fluid volume.
Good. Amazing.
Alhamdulillah.
Allah عليك. Yeah, perfect. So C. So how to answer this question? So you would look at a few things. First of all, you could see whether the intracellular fluid is increasing or decreasing. And here it says decreasing, right? So that means something outside is pulling the water that's in the cells towards it. So sodium. So when you see that the intracellular is decreasing, you will look for the highest concentration of sodium chloride. When you find the highest concentration of sodium chloride, they're probably all going to be the same volume. So you just choose the highest concentration of sodium chloride. If it says an increase in intracellular fluid volume, then the lowest concentration of sodium chloride, which would be the 0.45%. Tamam? So this question is quite important.
Okay, so which of the following describes passive immunity?
A.
Yeah, it's A. Everything else is active immunity, and there are only two examples of passive immunity. IgA passes from the mother to the baby via breast milk, and IgE passing from the mother to the baby while the baby is still in the womb. Okay?
Via placenta.
Yeah.
Okay, cardiac. In which phase of the ventricular muscle action potential is the sodium permeability the highest? Can you guys do this without a graph? I think I have a graph, but I'm not sure. I don't want to show the answer by accident. So phase 0 was going up. Phase 1 was the little thingy, the little repolarization. 2 was the plateau. Everyone's saying A, 0, yeah.
A.
Yeah. Good. I don't know how I didn't put a graph here. Forgot. Seems good. Do we need the functions of each immunoglobulins? I'm not
Yes,
sure.
you
I don't
need
think
to know. Yeah, there is a
Oh.
slide. There is a slide. Yeah, you have to know like key things. I have another question for IG immunoglobulins. I have another question, but you have to remember the key stuff about each immunoglobulin. Like IgA is found in mucous tissues. When there's like the question that says, oh, he has itching in his nose or rhinorrhea or rhinitis, whatever it is, anything,
Saliva.
huh? Saliva
Saliva.
also, yes,
Okay, I memorize
all
it.
IgA.
Saliva. I don't know how, but I just memorize it. Can you explain? Do you mean the previous question or the immunoglobulins? Okay. So during the depolarization, during phase 0, sodium would move into the cell, right? The cardiomyocyte, or here the ventricular cardiomyocyte. So that means that the sodium channels are open, so sodium can move into the cells. So that's the highest permeability of sodium. And as we see from the rest of the action potential, sodium doesn't move in or out anymore. Obviously, if you think about hyperpolarization, but that's another story. Does that answer your question? Okay.
Okay. So fluid exudation into the tissue in the acute inflammatory action is due to which of the following? This question just makes sense. Like it's common sense.
Oof, 3 different answers.
Yeah. Don't
Is it
overthink
E?
it, guys. It's E. I can see some overthinking going on. Don't overthink it. Like يعني, I know you guys will be like, oh, they would want a complex answer because this is a complex question. It's not. It's pretty simple, pretty easy. Why would fluid go out from the cell into the from the blood vessel into the cell? Because the blood vessel has
It's more permeable.
yeah. But
Yeah, don't overthink it. Good advice. Very, very good advice. Don't overthink stuff. Trust your gut. Okay. Which of the following is most likely to cause the heart rate to go into spastic contractions? So tetany. Hmm. Hmm.
E.
Yes, very good. Very, 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 very good. Quiz. Yeah, E. Excess extracellular calcium ions. Do you guys understand this?
I have a question though. I don't
تفضل.
really understand this. Isn't
طيب.
like the calcium there for like the plateau so it doesn't cause tetany?
Yes, but calcium is positive, right? If we have too much calcium, the plateau will just stay. So we will not repolarize.
Got it.
What is spastic? It says spastic. I misspelled it. Spastic contraction is so you know when you go to the gym and then you go home and your muscles kind of go like especially when you do leg day, your muscles kind of go. That's a spasm. Another name for it is tetany. Tetanic contractions, spastic contractions,
Basically, micro contractions,
micro contractions,
right after each other, like this.
like fibrillation.
Oh, don't go there.
Okay, you're welcome, and you're welcome for the person before. When you are free, may you go over absolute refractory, inshallah. Okay. Shall I just go through it quickly? Okay, so there are two periods, absolute refractory and relative refractory periods. The absolute refractory period is no action potential can happen during this time right now. Okay, the relative refractory period, if a stimulus is strong enough, then an action potential can happen. So the absolute refractory period is from the beginning of repolarization to before the threshold potential. Once we start hyperpolarizing, that is the relative refractory period, and strong enough stimulus can reinitiate an action potential.
You can remember it
Okay?
as absolute refractory, like absolutely not.
Not, absolutely not.
Yeah.
And the difference between an absolute and a relative, so the sodium channels in the beginning, they do not close. They do something called inactivation. Like Dr. Abdul Jabbar always seems so like adamant on making sure you guys know the difference between inactivated and closed. When it's inactivated, absolutely nothing will be able to open the sodium channels again until it reaches the hyperpolarized state where it will close. When it becomes closed, it can be reopened. Inactivated cannot be activated. Opened when sodium is going in, so during the depolarization, when we get to the threshold, now it's depolarization, it would be opened. It is inactivated when we are repolarizing threshold. So before we get to the threshold, it is inactivated. Once we get to the threshold, now we are starting to hyperpolarize, right? So when we start to hyperpolarize, so become even more negative than we should be, or when we were before, the sodium channels finally close. And then now with the strong enough stimulus, we can start up another action potential during this phase called the relative refractory period. Or I think there are like different names for it. So whatever name is in your slide, just follow that name. Okay. So
One question.
تفضلي.
Till which point is the sodium channel inactivated?
Until we get to the threshold, I believe. After the threshold, that's when we begin to hyperpolarize, right? When we start hyperpolarizing, then we are in the relative refractory period.
Okay, thank you.
You're welcome. Okay.
Okay. So, next question. An 8-year-old boy frequently comes to the clinic for persistent skin infections that do not heal within a normal time frame. He had a normal recovery from the measles. A check of his antibodies after immunizations yielded normal antibody responses. A defect in which of the following cells would most likely be the cause of continual infections? Okay. You guys are correct. It is C. Neutrophils are needed for routine infections, and the other cells like B lymphocytes, T lymphocytes, plasma cells, and macrophages, they're needed for acquired immune responses or like chronic. But neutrophils are active infections or acute infections.
It's okay, Faris, don't worry. It's okay to make a mistake. What about eosinophils, basophils? What do they do? I think one of them was for parasites,
Eosinophils for parasites.
and the other one was allergic reaction, basophils.
Hmm.
I believe
Aren't
they were
they
for allergic.
both for allergic reactions?
So eosinophil parasites, basically the way they work is the parasite itself doesn't give you an infection. The feces of the parasite gives you an infection. So it's kind of like roundworms. Yes, roundworms are parasites. Roundworms, ringworms, enterobia. Yeah, you guys don't know any of that.
Yeah,
But yeah,
just remember parasites, eosinophils, basophils, remember histamine
yeah.
production or histamine release.
So allergic reactions, basically.
Yeah. Neutrophils are for acute chronic, more not acute chronic, acute inflammation. They're quick
Yes.
response. As soon as you get an infection, they are the first there on the scene.
And once it
Uh,
becomes chronic, then we have lymphocytes.
Yeah.
So like TB, usually you have lymphocytes, but that's not important. Yeah, so eosinophils, I believe they can be for allergic reactions too. I do remember this, but usually it would be they'll ask you about parasites, and
Yeah, they can be for allergic
yeah.
reactions. Yeah.
Yeah. So keep in mind that basophils and eosinophils can be for allergic reactions, but basophils are more important because of the histamine release. Okay. You're welcome. طيب. What's the function of the plasma proteins in blood? Did you guys take Starling forces? Yes, Saad, Sidra, you are right. So to exert osmotic pressure to help maintain blood volume. Yeah. So plasma proteins made by like the liver, such and such, they increase the osmotic oncotic pressure, right? Or colloid pressure. They're both the same thing. Tamam? All good.
Oh, aren't B lymphocytes precursors to plasma proteins? Or am I mixing things up?
I don't think I've ever heard
No.
of that.
ولا أنا.
Okay. I swear I heard it in the lecture.
I'll make sure to look into that though. Why is it not D to function as non-specific body defense mechanisms? Why? I don't understand. Why would it be D? Why are they defense mechanisms? Doesn't plasma produce antibodies? Usually white blood cells produce antibodies, right?
No, plasma don't produce antibodies.
A friend cleared it out. It's plasma cells, not plasma proteins. But
Oh, okay. Okay, so yeah, no, this is plasma proteins, not cells.
And plasma proteins are not they don't have a role in body defense mechanism. They're not immune cells in any form,
Yeah, just proteins.
nor they are produced by immune cells. So they have nothing to do with the immune response.
Okay, I guess I kind of mixed you guys up. I'm sorry for that. Because plasma cells, I'm not really sure actually. I'll have to look into that. I don't really remember
Plasma cells are similar to B lymphocytes. Remember, we took them in POD, secreting immunoglobulins or antibodies.
Okay.
They also act like antigen-presenting cells too.
Okay.
Mm.
I'll have to review that. B cells differentiate into plasma cells. Okay. Okay. Good. Okay. So no, this is plasma proteins, not plasma cells. Sorry for the mix-up, but I did mention that they were made in the liver. Mostly any proteins are made in the liver, or like digested basically. Okay, so is the confusion like cleared up? Phagocytosis are a non-specific defense mechanism. So I guess you mean
phagocytosis is not specific.
No, it's not specific. It can be for any cells. Any lysosomes do phagocytosis. It's a process.
Neutrophils, macrophages, they all phagocytose.
You're welcome. Okay.
Okay, so in regards to leukocyte extravasation, which of the following types of leukocyte is normally the first to exit the blood vessel at the injury site in response to an inflammatory stimulus? This is again the same question that we just solved, but just in other wording. Wink, wink, it's high yield. Yes, you guys are right. It's neutrophils. They're the first to react to any infection.
Yeah. And when it becomes chronic, sites. So two-parter. Okay, this one is okay. The figure above or to the right represents various states of abnormal hydration. In each diagram, normal state, which are orange and lavender, and the dashed lines are abnormal. Okay, so dashed is abnormal. Illustrate the shifts in the volume, which is the width, and the total osmolarity, which is the height of the extracellular and intracellular fluid compartments. Use this figure to answer question 31 and 32. So which diagram represents the changes after osmotic equilibrium, in extracellular and intracellular fluid volume and osmolarity in a patient with the syndrome of inappropriate antidiuretic hormone, so excessive antidiuretic hormone release? Which one would it be if someone has a lot of ADH? Okay, Faisal is right. Ooh, okay. Yeah, I guess I have to explain this. No, so the answer would be B here. So the excessive secretion of ADH would increase the renal tubular reabsorption of water, right? So we'll have a lot of water, so we'll have a lot of extracellular fluid volume. So if you have a lot of extracellular fluid volume, the intracellular fluid would so we'd have a reduced osmolarity, right? Which would cause water to flow into the cells, and it would raise the intracellular fluid volume. Gain of hypotonic fluid. This is gain of sodium and water. Reduce osmolarity, yes. It would reduce osmolarity. So in steady state, both extracellular and intracellular fluid volumes would increase. So both compartments would decrease in osmolarity. It's basically you're filling it up with water. Okay. Oh, I forgot I did this. Yeah. Okay, so it was B. So which diagram represents the changes after osmotic equilibrium in extracellular and intracellular fluid volume osmolarities after the infusion of 3% sodium chloride? Which is a question we answered before, right? So what would happen? Yes, okay, you guys get it. Good. Okay, good. I'm glad you guys understand now. C, yes, please. Okay, good. Okay, interesting question.
A 45-year-old patient presents with diarrhea and blood in his stools. These symptoms started about 2 years ago and became gradually more severe. 3 days ago, the man developed fever and extreme fatigue. His gastrointestinal discomfort is now significantly worse, with up to 10 stools per day, accompanied by severe cramps and blood loss. A complete blood count showed a hemoglobin concentration of 11, erythrocyte sedimentation rate of 50, and a high sensitivity C-reactive protein level of 4. A fast check stool culture reveals a presence of bacteria. An endoscopic picture of the large intestinal wall is shown in the image. Which of the following combinations of inflammatory cells would most likely be present in a colonic biopsy sample? This is a long question, but remember, this problem has been going on for 2 years, but he has an active infection. So which set?
F.
Okay.
No? All right.
Now I want to see what other people would say. Okay, there are a lot of mixed answers, but it's F. Whoever said F,
Let's go.
hooray. Macrophages and lymphocytes are for chronic infections because this guy has been having this problem for 2 years. This is chronicity. But it's also getting worse and progressing. That means there is also an active infection going on. And remember we said neutrophils are for active infections or acute infections, stuff that are going on right now. So we have to have neutrophils, macrophages, and lymphocytes in the same option. So the first one says basophils, eosinophils, and mast cells, all of which are not related to infections by bacteria. Basophils, eosinophils, and neutrophils, they don't, again, basophils and eosinophils, not related to bacteria infections. Macrophages, basophils, and mast cells. This option lacks neutrophils. None of the cells over here are for acute or ongoing infection. Macrophages, lymphocytes, and plasma cells, again, these are all chronic. Neutrophils, basophils, and mast cells have nothing to do with this. The only option is neutrophils, macrophages, and lymphocytes. Yes, macrophages and lymphocytes are for chronic infection. It takes a while for them to react to whatever infection going on.
And they live long. Okay. Which condition at the AV node will cause a decrease in heart rate? So which will give us bradycardia?
B.
Say that again.
If I'm being honest, I don't know, but B. That's my guess.
It's okay. You can guess. That's fine. Okay, so decreased acetylcholine. Okay. C. Okay. So let me explain this to you guys. So let's think of this through action potential. Let's see if you guys change your answers, because until now, none of you have gotten it right.
One person got it right.
Oh yeah, my bad. Well, now they know the answer.
No, two.
Yeah. So the answer is D, the increased potassium permeability. It is D, yes, it is D. How? Okay, let me explain how. So, yes, potassium is a positive ion. I do understand that. But potassium's equilibrium potential is very negative. So that means it would leave the cell, making it even more negative and hyperpolarizing it. So if it was more permeable, or the permeability for potassium was higher, the potassium would leave, trying to get to its equilibrium potential, which is more negative than normal, which is around like -90. So it would be way more difficult for for the cardiomyocyte or the AV node to elicit an action potential. Does that make sense? Because its equilibrium potential is negative, it will leave the cell, making the cell more negative, since it is more permeable right now. Does that answer your question, Sidra? I would love a reply. Guess I'll just move on. Okay. I hope you understand. If you don't, please let me know, because this can be important. Okay.
Okay, so which is the right sequence for migration of blood leukocytes to tissues? Okay, mashallah, you guys are right. It's A. Rolling, integrin activation by chemokines, adhesion, then diapedesis. Can you move to the next slide? I have a picture.
Is this from Abrar's lecture?
No. So what we use for rolling, for immune cell rolling on the endothelium is selectins. As you can see here, so the selectin ligand, the pink thing on the cell, will bind to the selectin on the endothelium. It will roll until the integrin binds to the integrin ligand on the endothelium. That causes adhesion. The cell will adhere to the endothelium, will stick to it. And then using the PCAM, this will mediate the infiltration of the immune cell inside the cell from the lumen of the blood vessel inside the interstitial place or area. Okay, this is the sequence: rolling, integrin activation by chemokines, stable adhesion, then migration into the endothelium. Is that understood by everyone?
Okay.
Okay.
Guys, is it okay if we take more time, because a lot of these questions I left at the end are very important and you guys asked for them. So we might need like another 15, maybe 20 minutes. Is that okay with you guys? Of course, okay.
Yep.
Okay, good. No, I really don't want to tire you guys out, but this is very helpful, yani. I hope, yani. Okay. So, inshallah, we can finish quickly. So, again, with the electrolytes, intravenous infusion of a liter of 0.45 sodium chloride solution, and a molecular weight, whatever, would cause which of the following changes after osmotic equilibrium? So if you remember, this is the least solution of saline we had in the previous question, least concentration of sodium chloride in saline. So what would happen?
Can I go like step by step, or should I just say the answer?
Go ahead.
All right, so we're adding 1 liter, so extracellular fluid would increase like last time. The osmolarity of both would also increase.
What did you say? The osmolarity would what?
Would increase. No?
Okay. No,
Okay,
not
has a lot
exactly.
of like hesitation. Okay. Yeah.
So no, it wouldn't increase. No. This is a relatively low concentration of sodium chloride, but I'm glad you tried it. That's very good. So when you see, and it's intra will not osmolarity or volume. Mubarak. Yeah, B is the answer. Yeah, B is the answer. Yeah. So intracellular fluid volume would increase and osmolarity would decrease. Extracellular fluid volume would increase and osmolarity would decrease. So basically, you can think of this as what? Just normal. You're just giving water.
Wait, but aren't you're adding 0.45 NaCl to like, or is that wrong?
It's, yeah, 0.45%. It's
So you're-
hypotonic. It's hypotonic.
Bismillah.
So it's a hypotonic solution of sodium chloride, right? It would initially increase the extracellular fluid volume and decrease the extracellular fluid osmolarity. The reduction of the extracellular fluid osmolarity would cause osmotic flow into the cells, thereby increasing intracellular fluid volume and decreasing intracellular fluid osmolarity. After osmotic equilibrium, obviously. Okay.
A 45-year-old man presents to the emergency room with a 2-week history of diarrhea that has gotten progressively worse over the last several days. He has minimal urinal urine
Hey.
output, and it is
It's parasite.
amazing, mashallah. His stool specimen is positive for parasitic eggs. Yeah, it's A.
Yes. Faisal, خلاص والله we know you know it's A.
خلاص
والله.
خلاص.
Okay. The sensitivity of smooth muscle contractile apparatus to calcium is known to increase in the steady state under normal conditions. This increase in calcium sensitivity can be attributed to a decrease in the levels of which of the following substances.
Wait, is it C?
It is not C, no.
No, it's C. I'm saying it's C.
E?
E.
C.
Yeah, it is E.
Oh.
My bad.
لا عادي.
Yeah, E. Okay, good.
Okay. Where does the transmigration of WBCs occur in response
Sorry
to
to interrupt you,
infectious
but
agents?
1 second, they don't understand.
Okay.
So the sensitivity of smooth muscle contractile apparatus to calcium is known to increase in the steady state under normal conditions. So if we increase calcium sensitivity, so the increase in calcium sensitivity can be attributed to a decrease in the levels of which of the following. So which of the following would have to decrease to increase the sensitivity of calcium? So myosin light chain phosphatase, this dephosphorylates the myosin light chain, right? So it becomes inactive and therefore attenuating the muscle contraction. So for choice A, both actin and myosin are important, but the smooth muscle contractile apparatus for the smooth muscle contractile apparatus, much like that of skeletal muscle and cardiac, but they don't play a role in calcium sensitivity. ATP is required for smooth muscle contraction, and decreased ATP level would be expected to decrease the ability of smooth muscles to contract, right? As for C, calcium calmodulin complex binds with the myosin light chain kinase, right? Which leads to the phosphorylation of the myosin light chain rather than dephosphorylation, and a decrease in the calcium calmodulin complex would attenuate the contraction of smooth muscle. And for D, the binding of the calcium ions to calmodulin is an initial step in the activation of the smooth muscle. Basically means less contractions.
Does it mean stronger contractions?
Yeah, I think it means stronger contractions. So it's more easy to contract. So smooth muscles, they have different degrees of tension, right? At a constant, what is MLCP? Myosin light chain phosphatase, right? So it dephosphorylates the light chain. So it basically makes it inactive. MLCP makes it inactive. MLCK makes it active. So if we take away the thing that makes it inactive, it will become easier to activate.
Yes, helps in relaxation.
Yeah, helps in relaxation. I didn't explain this really well, but I hope you guys understand. So MLCP inactivates, MLCK activates. So you remove the inhibitor, you stimulate it more, right?
There's a balance between MLCK and MLCP.
MLCP.
You tip the balance into MLCK's favor. That means there's going to be more contraction. And if you do the opposite, you tip it towards MLCP, you're going to have more relaxation.
I hope that makes sense. Because you decrease MLCP means more contractions, yani calcium sensitivity. Yeah. So basically, you don't need as much calcium as you did before. Okay, good. You're welcome.
Okay. Where does the transmigration of WBCs occur in response? I think we did this, right? No, wait, we didn't. Where does the transmigration of WBCs occur in response to
B.
infectious agents?
B.
Think again. WBCs, they won't be in lymphatic ducts, would they?
If they're in the lymphatics, then we're not using them, right?
Yeah. Okay, so the answer is C. Why is it C? Because the transmigration of WBCs is going to be easier through parts of the vasculature that have very thin walls and minimal smooth muscle layers. So it's easier for it to move from inside the venule or from inside the blood vessel into into the cells. So this
And
includes capillaries and venules.
yeah, arterioles are called the pressure vessels, so it's kind of difficult for that. Doing that. Plus they're okay, خلاص تمام. Okay. So and next question. The excitatory or inhibitory action of a neurotransmitter is determined by which of the following? So what determines whether a neurotransmitter is inhibitory or excitatory? Excitatory. Come on. Yes. Why are you guys confused? Yeah, it is A. Yeah. So if the receptor is excitatory, it will be excitatory. If it's inhibitory, it will be inhibitory. Neuro is not hard.
Take that back. Oh, we already did this question.
Yeah,
Oh,
that
okay.
was C.
Yeah.
Yes. Shalatic. Bro said, all right, bro. Okay, I'm sorry. I like neuro. I muted myself for this. Okay. A 2-year-old patient presents with episodic headaches, sweating, tachycardia. It was later discovered that she had a neuroendocrine tumor and of the adrenal medulla, which originates from from chromaffin cells along the paravertebral sympathetic chain, extending from the pelvis to the base of the skull. Which of the following is the most likely diagnosis? Adrenal medulla, paravertebral sympathetic.
C.
What did you say?
C.
C?
It's either C or A, since we're talking about either A or C.
Only one of the
What?
only one of the answers includes the adrenal medulla. Only
Wait, this
one.
was in your lecture, right? It was. I saw it in the lecture, I'm sure.
Maybe it was briefly mentioned.
Yeah, no, it was. There was a whole slide for it.
Wallah.
Yeah. So basically it's a pheochromocytoma. You guys said hyperthyroidism because you read the word neuroendocrine, right? So the adrenal gland is part of the endocrine system too. And the adrenal gland, they give you your, this is in the ANS lecture. ANS lecture. There were 2 slides at the end of the lecture, 2 different diseases. Very, very important. You'll see these diseases in every single block.
Yeah.
It is B, yes, pheochromocytoma. You'll see the other disease, actually, I had a question for
You guys just finding out about a whole slide.
okay. Well, I'm glad I
But
opened your
good
eyes
we
to
brought
it.
the question, yani.
Yes, this is from the ANS lecture, physiology, not the function one, not the structure one. Bismillah. Don't worry, guys. This is easy. Don't worry. Listen. Yeah, AJ. Of course, AJ.
Who
Okay.
else?
Okay, listen. So a pheochromocytoma is simple. You'll have catecholamines, you'll have headaches, you'll have sweating, tachycardia. So your sympathetic system is constantly
Yeah.
working, right?
Catecholamines is steroids, basically.
Yeah, so your epinephrine, norepinephrine, right?
Yeah.
So when you see adrenal medulla, you see chromaffin cells, you see a lot of epinephrine, you see tachycardia, you see vasoconstriction, stuff
So you're
like that.
basically in fight and flight.
So yeah, sympathetic, fight or flight, yes. Yes, that's an easy way to put it. Good. Thank you for that. Okay. It was before Horner syndrome. Okay, thank you for spoiling. Okay, so a 6-year-old boy presents to the neurology department with unilateral ptosis, meiosis, anhidrosis, and anophthalmos. Which of the following is the mechanism of the presentation in this patient? So I didn't say it was Horner syndrome. I want you guys to tell me how Horner syndrome works. But it is Horner syndrome, yes. So I thought this might happen. Yeah, like someone would see pheochromocytoma, paralysis of the superior cervical sympathetic ganglia. You are absolutely right, yes. So I don't think they said cervical sympathetic for you guys, but it is cervical, okay? It is the superior one. Yes, A. Okay, good. Does anyone not understand Horner syndrome? Tell this is very important. This is very, very important. So
All right,
let me
repeat
explain
it,
it to you guys
just in
now.
case.
Okay. So Horner syndrome. Unilateral means on one side. You'll have ptosis, which is drooping of the eyelid. You'll have meiosis, which is pupillary constriction. You'll have anhidrosis, which is no sweating, and enophthalmos, which is the eye
Bulging
pushing
out.
in. No, that's exophthalmos.
Oh, sorry.
Yeah, no, it's okay. So enophthalmos is the eye bulging in rather than being how it is like this. And exophthalmos, which is not here, the eye will be kind of like bulging out and like, right in front of you. So if you see these 4 things, Horner syndrome, no doubt. Unilateral ptosis, meiosis, anhidrosis, and enophthalmos. Horner syndrome, على طول. Superior cervical sympathetic ganglia. Inhibition or paralysis. تمام? So this is a picture of Horner syndrome, as you can see here. So you can see the pupil is constricted, which is meiosis. Can you explain the last question, the disease, Yani? Yeah, okay. So you have something called the superior cervical ganglion. It is it's part of your nervous system, your spinal cord, your sympathetic chain. Okay? So when your sympathetic chain, or not yours, this patient's sympathetic chain is paralyzed or inhibited due to some reason, you will present, or this patient will present with Horner syndrome. Horner syndrome is characterized, and the meaning of a syndrome, by the way, is a group of symptoms that are very specific for a certain disease. So when you have these 4 symptoms, you have Horner's syndrome. So Horner syndrome is meiosis, which is the constriction of the pupil. You have anhidrosis, which is lack of sweat. You have ptosis, which is the drooping of the eyelid. As you can see, the upper eyelid is closed compared to the right eye. And you will have enophthalmos. So this eye, the left eye, you can, if you could really look at it, you can tell that the eye is into the orbit more compared to the right eye. تمام. Rida or Rida, I'm
Okay.
sorry, I don't know how to pronounce your name. I'm so sorry. Okay. تمام. Does anyone need any explanation for Horner syndrome? Didn't know this. I made a huge mistake in first year. We took it in MSK though. I made a huge mistake. So guys, please don't make the mistake I made. It was an SAQ. I fumbled it. Okay. Which substance activates the adrenergic alpha and beta receptors equally well? Keyword adrenergic.
B.
Okay, can you guys guess again? Yeah, see, epinephrine.
Yeah, see.
Yeah, so adrenergic means adrenaline, and adrenaline is epinephrine. So norepinephrine excites both types of receptors, but has markedly greater effect on alpha. So epinephrine does both equally well, okay? Norepinephrine has a higher effect on alpha receptors, okay? So remember this. We're almost done, inshallah. Okay, another ANS lecture question كده ANS ورا بعض. Which of the following correctly describes the effect of a drug?
Wait, this was I think A. No, either A or E. Wait,
Yes, again.
so it's neither.
Neither, no, not A nor E.
Hmm.
Okay, so let's beta 1,
C.
okay? What does beta 1 do?
C.
Okay, yes, okay. So we have 2, right? We have 1 heart and 2 lungs. I almost said 3. We have 2 lungs. So beta 2 works on the lungs and beta 1 works on the heart. Okay? So when we stimulate beta 1, you'll have increased chronotropic and inotropic effect. So chronotropic refers to heart rate, and inotropic refers to contractility. You'll learn
No,
this inshallah.
chronotropic is contractility. Right? Chronotropic, contractility, CC.
No, chronotropic is like time. So like Chronos, like from mythology, is the god of
Rate.
time.
Yeah.
Yeah. Okay, so contractility is inotropic. Yeah.
Choice B is beta 3, right?
Choice 3 is beta 3. Yes, lipolysis and increase in thermogenesis of brown fat. Yes. Beta 3. And beta 2 is A.
I thank you.
You're welcome. Most welcome. Okay. So which of these directly correlates to على طول جاوب ما شاء الله to total body iron stores and what type of anemia? Say that again.
D.
D. Beta 1 increases the heart rate. Yes, yeah, Faisal. Yes, D. Is there a confusion in the adrenergic receptors? Is there confusion here? Okay. Okay, تمام. Which of the following exports iron across the basal, ما شاء الله على طول, basal membrane into the blood where it's transported by transferrin? Ferroportin, yes.
The PowerPoint was definitely leaked to Saad.
ما شاء الله ما شاء الله ما شاء الله
ما شاء الله تبارك
الله
الله
تبارك الله
يعني
الله قوة إلا بالله
too prepared for us يعني
ما شاء الله ما شاء الله. Okay, which of the following binds to ferroportin and prevents release of iron?
A.
Yeah, ما شاء الله صحيح. Okay, good. Good, good, good. You guys studied this well. Why did you ask for it in the? This was like the most asked for lecture.
Yeah.
27 out of 34 asked for this lecture. Okay. You are attending to a 27-year-old male patient presenting with hypogonadism and cardiomyopathy. Additional testing has confirmed that the patient is suffering from juvenile hemochromatosis type 2A. This disorder results from a defect in the gene encoding the hemojuvelin protein.
D.
The expression,
B or D. It's B or D.
choose one. The expression of which of the following proteins would likely be unregulated in this patient?
B.
No.
It's D then.
Hemochromatosis is too much iron.
So hepcidin. Well, no.
It is D, yes. D. So juvenile hemochromatosis. So it's the result of defects in the gene encoding for HJV. The function of HJV is to regulate the expression of hepcidin, of the hepcidin gene. Unregulated expression of hepcidin allows for increased iron uptake, resulting in iron overload, typical in hemochromatosis. This is from the iron metabolism lecture. Everyone asked for this lecture. Okay, so hemochromatosis is too much iron, and if we don't have enough hepcidin, you will constantly uptake iron, leading to hemochromatosis. I'm not sure if you guys took HJV or juvenile hemochromatosis, but this was just to tell you about hemochromatosis because, okay, good. But I remember I saw the lecture and you guys took hepcidin deficiency would cause hemochromatosis. Okay, that was good. Okay, the level of iron in the body must be tightly regulated due to severe toxicity associated with elevated levels in the circulation and within cells. Which of the following proteins is primarily responsible for
E.
iron homeostasis?
E.
Yes, good, Yasser. Shut. Yes, E. Fair, transferrin. We're almost done. 6 slides left. Okay, so the loss or deficiency in which of the following proteins will result in the inability of transferrin to bind and transport iron in the blood?
B.
Guess again. Yes. Sidra, Hiba. Yes, E. Hephaestin. I saw this from the slide, so I got a question about it. Okay. So I left this for the end because it's kind of confusing. The Nernst equation, or Nernst equation, however you want to pronounce it. Do you guys want to go through this? Okay. Okay, so the Nernst equation. Does anyone know how to solve the Nernst using the Nernst equation? No, it's not. It's not D, no.
Is it E?
Is it what?
E?
Yeah, it's E, yes. Yes. Very
Please
good,
don't
mashallah.
ask me how I got it.
No, it's okay. So the Nernst equation is horrible, honestly.
Yeah.
To be honest, I saw it
Yes,
from the last
exactly. It's negative
years.
62 log inside al outside. So negative 62 log or multiplied by the log of so basically 5 divided by 125. Would you guys like me to annotate?
Yes, please.
So we got these numbers from here, this 5. So it was asking for the equilibrium potential of chloride in millivolts, right? I don't know why this line is like that. Anyway, so there's 5 and there's 125. 5 is intra, 125 is extra, right? So 5 over 125. So the equilibrium potential in millivolts is negative 62 or positive 61. It says here, I don't know why, but I solved it here in a negative. Multiplied by the log of, bro, I don't know how to write on this, but here, like this. I don't think you'll be given the formula in the exam, but yani just remember the Z number or the Z valency basically multiplied by the log of intracellular versus divided by extracellular. Where did the 61 come from? Wallahi, very good question. You are most welcome. Well, I'm not sure where the 61 came from. I'm not gonna lie. I'm not gonna lie. You will get a bunch of these questions in your final. It's a constant, okay? It's a constant. I remember there was a constant, but I thought it was something over Z. Well, I guess, yeah, it is a constant. Yeah, we just took it as 61, right? They just told you to use 61 log. It's always negative 60, 61, 62, which are the same, yeah. Yes, always negative 61 multiplied by log of ICF over ECF. You will have calculators in your exam soft. Don't worry about that. Okay, we can end the recording now and take questions, just so the recording isn't that long. Please, guys, scan this and tell us what we can improve